Hello everyone, this is CHADI ALRAIES from SIF 2025. I'm really privileged to be with Dr. LINDSEY CILIA to talk about management and update for cardiogenic shock in 2025. Lindsay, thanks for being with us.
Thanks so much for having me.
So Lindsay, you perform and you're leading the complex and CHIP programs in Virginia, but definitely shock patients are considered complex, whether it's cerebral conduit or CTO, whatever it is. So tell us about your program and the structure and where we are now.
Excellent. So at Inova, we have a very well-organized cardiogenic shock team program, and it really starts with early recognition and identification and classification of shock.
Yeah.
And so what happens is we educated and taught all of these surrounding facilities in our catchment area about shock and told them when to call and how to call, and we make it easy for them. And what they do is just when they identify shock and they feel that they have a sick cardiogenic shock patient, whether it's heart failure cardiogenic shock or AMI cardiogenic shock, they pick up the phone, call the access line, and then the access line gets the interventionalist, the advanced heart failure doc, ICU doc, and cardiac surgeon on the line to talk about the patient and then institute the care for the patient, direct them where to go.
Yeah. So is there anything you require from the referring physician or referring hospital to do before refer, like certain data you ask for, or you say, bring him over, we'll take care of it?
Very good question. And so, our motto is call early and call often.
Yeah.
However, we like a basic physical exam, whether the patient is fluid volume overloaded or, basics of an EKG, basics that in numbers, whether it's lactate, kidney function, LFTs. If the referring hospital can form a PA catheter, get invasive hemodynamic measurements, that's incredibly helpful. But if it's more of a urgent care setting, any information is key. History, physical exam, maybe a bedside ultrasound, POCUS, just to see how the heart looks.
Yeah. And then once the patient arrives to you, around 1 o'clock in the morning, 8 p.m. at night, so there's a team receiving that patient.
Correct.
And I am assuming on the phone you triage this patient to see if he's going to surgery or to you. So how do you make that determination?
Good question. So typically we come up with a plan even before the patient's transferred. For example, if we know the patient needs ECMO cannulation, we'll activate the team and have the team ready.
Yeah.
Maybe the patient's going to the cath lab for an Impella and PCI because it's a clear cardiogenic shock AMI patient. So we have the plan in place. If it's undifferentiated and we're not really sure, we have 24-hour monitoring in our CICU, and so the patient goes to the CICU. If they don't have a SWAN yet, we'll pace a SWAN, start inotropes and pressors, whatever is needed, start diuresis if needed. And so we kind of further differentiate the type of shock in the ICU if it's not clearly defined upon arrival.
And then So how in your center, I think different centers do ECMO, like sometimes interventional, sometimes surgery. So how do you determine the patient need and who will take over once your ECMO is inserted or cannulated?
Great question. So at our institution, cardiac surgeons cannulate for ECMO, and after ECMO cannulation, we have MCCS, which are intensivists that take over that care. So we have two teams in the ICU, the CICU. We have a teaching team and we have a non-teaching team, and on the non-teaching team, it's the MCCS intensivists that are taking care of those ECMO patients alongside consultants like interventionalists or advanced heart failure docs to kind of manage that care.
We know that weaning and escalation is very important in these patients because sometimes they have a nice progression versus sometimes they don't. So, and care is very important. So what kind of algorithm or checklist you have in the CCU or an ICU for these patients?
It's a great question. And so, once you call the shock call and you initiate the shock call and transfer the patient, the shock team care does not stop there. It's through the patient's hospitalization. Sometimes post-discharge, we now have a cardiogenic shock post-clinic that they follow up with and make sure that they get all the care that they need. And so once we cannulate and we have to go over weaning protocols, it's really the intensivists along with the consultants kind of doing that on a daily basis, reassessing all of the needs of the patient.
Nice. De-escalation. Is it something that the intensivist will do? But is there certain parameters that publish or from the shock guidelines that you implement in your practice?
So we're actually trying to come up with a set protocol now as well, to follow and kind of organize to kind of see when, it's the area is there's so much growth and room for growth. And so it's a really great question. We're actually in the works of creating some set specific algorithm, but nothing definite yet, kind of patient by patient basis.
Right. And I'm assuming you're involving not just physician, also nursing and allied health being team to help you with that as well.
Exactly. Bedside nurse is key, important players here, and so it's a team aspect. All the consultants and also all of the physicians.
Yeah. Well, Dr. Cilia, thank you so much again for enlightening us about this algorithm. Again, I think this program that you have now is pockets in the United States. We don't have them on a broader spectrum, but hopefully one day we'll have a more centralized process where everybody follow the protocol.
The goal is to wherever the patient kind of shows up for that care, that they get the same care everywhere.
Exactly. Yeah. Standardized. Thank you so much again for your time. Watch these videos and others on SIF YouTube channel. This is CHADI ALRAIES coming to you from Scottsdale, SIF 2025. Dr. Cilia, thanks again.
Thank you so much.
Thank you. Thank you.